this afternoon's next presentation is on a great topic I'm looking forward to learning because I don't know much about this, fortunately or unfortunately, long COVID. And Dr. Farah Ikramuddin is an assistant professor in the Department of Rehabilitation at the University of Minnesota. She has a focus in stroke rehab and has conducted clinical trials evaluating different modalities in post-stroke rehabilitation. She's been on the front lines during the pandemic, haven't we all? And currently helps lead the long COVID clinic. I didn't know we had a long COVID clinic, so I'm really going to learn a lot about this. She is an active member on the Medical School Admission Committee and currently serves as medical director of what we fondly used to call FUTS, which apparently now is the Transitional Care Unit at the mHealth Fairview system. She's active in training medical students, residents, and students in allied health programs, interdisciplinary. Thank you. Thank you for joining us today and giving us your expertise. Do you want this on?
Thank you, Terry. From what I understand, Terry was the medical director of the same TCU that I am of today, so it's a full circle today. So, and I'd like to thank the Minnesota Association of Geriatrics for inviting me for talking about the long COVID. Part of my talk would be about long COVID, and then we'll focus more on the elderly population. So these are the objectives of my talk today. I have no financial disclosures today to talk about. And so long COVID. So how many of you know about long COVID or know someone specifically with long COVID? Excellent. So a lot of us know about what this is. Major public health concern at this point today, because it directly relates to workability, right? So it really is looking at eventually at the GDP of our country. So very important. Long COVID was first described in May of 2020 by an Italian patient on Twitter. Go figure, right? And that's our world we live in. That's about probably the same time I probably started noticing the patients we were discharging from the hospital. And I was seeing them in follow-up, looked like they were really having some symptoms, were not bouncing back, right? So that's about, but we think of long COVID and we say, wow, this is the disease of the pandemic, but actually, some ways it's not, because there is the myalgic encephalopathy described by Dr. Fauci, or chronic fatigue syndrome, that also occurs after other infections, right? The only thing is, as physicians, we have kind of put that chronic fatigue syndrome under the carpet because we don't want to see it. Well, now, because of the pandemic and the numbers that we see around us of long COVID patients, we can no longer do that. That's why it takes the center stage. It's not completely new in some ways. Okay. Oh. Go back. So one of the things about long COVID is PEM, post-exertional malaise. This is the part of the chronic fatigue syndrome. Actually, we've known PEM as part of the chronic fatigue syndrome. Now it's part of the long COVID as well. And you would say, what is PEM? Very important. All the patient advocates and the patient groups that are being formed around long COVID, they have a lot of concern around PEM. If you look at PEM, what it will show is that you have overexertion that leads to increased symptoms, maybe 24 to 48 hours. Now, your overexertion does not need to be you went out and cleaned up all the leaves in your backyard on a good fall day. It means that you might have been stressed about something somebody said. That will also lead to increased symptoms. So that there is almost like a punishment for overdoing something. And that then when you do rest yourself, then the symptoms get reduced. This is a major barrier for me as a physiatrist who's telling my patients, you need to do something. You need to move so that you don't get deconditioned. PEM is a major barrier because I can't push my patients to become more active as long as this vicious circle is there. Even if I refer them to PT, they're going to go to PT and they are going to not go to PT the next day because of PEM. And PEM is not new to us. It's part of the chronic fatigue syndrome, which is why this slide came up a little bit early. So what is the definition of long COVID syndrome? What is it called? And that's where how broad this horizon is kind of becomes evident to us. It can be long COVID. It's called long haulers. It's called long COVID syndrome. NIH calls it post-acute sequelae of COVID, PASC. So the names are many-fold. And the definition also varies depending on who you look at which organization you're looking at. So if you look at CDC, CDC says that if you have a history of probable or confirmed SARS-CoV-2 infection. So that's very important. Why probable? And for this, you have to go back to our early pandemic, where patients were getting infected, but they were being told, no, just don't come to the hospital. Come only if you have shortness of breath that maybe you'll get intubated. So these patients never really got confirmed COVID. And what do we do with them, right? So it becomes important because many of the clinics, the long COVID clinics, will say you can be you can be seen by a physician or a provider in the long COVID clinic if you are PCR positive. So what happens to all these patients who in the early 2020 did not get diagnosed with a PCR? So we have to be very thoughtful about who we diagnose and what we tell our patients. So anyway, CDC says that usually 3 months after the onset, if the symptoms last at least for 2 months and cannot be explained by another reason. And another or alternative diagnosis becomes very important. I've had patients who come to me, and this particular patient was having palpitations and shortness of breath, very much long COVID symptoms. Something about her triggered me to send her to a cardiologist who got an echo, and she was found to have a PFO. So there is a very fine line that we have to run between, okay, do I go and start that $1 million workup or do I hold off? Right, very, very important. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, and these symptoms might have started right with the COVID or might have been a period of no symptoms and then restart. This becomes very important when you're studying the mechanism of long COVID. And these symptoms can fluctuate. So that's CDC. If you look at WHO, what it does is says that you have to be post-COVID 4 weeks after. So you can be diagnosed with long COVID 4 weeks after the diagnosis of the acute COVID itself, and then puts it down into 4 buckets. I somewhat like this definition better because in my mind, when I see these patients, there are 2 kinds. The first one is the post-intensive care syndrome. So these are the patients who went to the ICU, got intubated, got ECMOs. Some of them I have seen myself were intubated for as long as 7 weeks. I've seen patients when they were extubated with facial atrophy that I've never seen before. So those patients really are the picks. They have significant and severe atrophy of their body. I mean, I'm talking about facial muscles. You can imagine what happens to their muscles throughout the body. So that's the PICS. Then there is the PEM we talked about. Then is the multi-system inflammatory syndrome, which could be, I'm seeing patients who are developing hyperthyroidism, hypothyroidism, many kinds of, I'm seeing Guillain-Barré syndrome, even some after vaccination, autoimmune conditions. So there are 4 buckets that WHO puts them in. So a little different diagnosis and different approach. So you can imagine for a researcher, you begin with which definition are you going to start with and what will be the name. I mean, even when I write a manuscript, I have to be careful that I start my manuscript with one particular name of long COVID and stay with it till the end because there are just so many names. These are the other important organizations. NICE is from England, Scottish Intercollegiate, and so all of these have a different way they look at long COVID and actually COVID, where they talk about the acute COVID up to 4 weeks, and after 12 weeks is their long COVID, and in between is the ongoing symptomatic COVID, okay? Something just to know about. Oops. Okay, So now this is based on one study, and this study shows what are the symptoms of long COVID. There is one study that has produced about 200 symptoms of long COVID. There is another study with 50 symptoms. But I like this particular one because it kind of tends to, I don't know if I can, no. So it kind of puts it into buckets. The one I like to start with is the general symptoms, which is basically your systematic symptoms, such as fatigue, and peripheral neuropathies and joint pains, general aches and pains, and generalized weakness. But these are systematic symptoms. Others are neurologic, psychiatric, cardiovascular, pulmonary, cutaneous, and neurological. So I like to see those buckets because I think that's how we can study the mechanism a little bit better by putting them in various cohorts. Mechanism of COVID, long COVID is a rather a long topic, but what I can tell you is that the recent research is showing that overall that's the picture that is emerging is that there is close interaction between the neural parts and the immune parts of the body. So before we always thought that there was not a whole lot of connection, and I'll show you a slide down the road which kind of tells you how it works. The other thought is there is virus triggered hyperactivity of the immune system that stays together. Now we know from studies that yes, CRP levels are going up and interleukin 6 and 12 go up in the acute phase, but we have not consistently shown that in the long COVID patients. There are not enough large studies to say yes, that is the case. Smaller studies are still available. And what happens is that this status of being in a hyperinflamed state, where is what I target that part for treatment. There is the body goes into a status of hyperinflammation where it stays even after the acute phase and then impacts a lot of organs kind of producing your symptoms. What I have seen personally, anecdotally in my clinic is that those patients who might have been hovering or with a disease but hadn't actually shown up, it will unmask all those. If you had a susceptibility to migraine because you had a family history of migraines and you now had COVID, well, long COVID is going to bring it up for you. So there is a lot of unmasking, and that's because I believe that there is a setting of the inflammation in your body that kind of unmasks those diseases for you. Once independent of the virus, this inflammatory state keeps high. Are there studies that show there is increased levels of CRP? Not at big levels, not at high samples, just small samples. I have one patient who actually developed chest pain and chest tightness after getting the acute COVID. And this is 1.5 years after the acute COVID. His troponin levels are still high. You can imagine that. But again, we don't have large studies with large samples to actually say that, yes, that is the case. Okay, now we got this. So what are the mechanisms? Other mechanisms, there is one study, very interesting, and that's the study that I've put it down. It's called Catch Me If You Can. So this is a study of about, I think there were about 48 patients who were whose brains were on autopsy studied, and what they found is actually the viral RNA in their brains in more than 57% of the patients. There's another small study from the University of Minnesota. This is a study of just 3 patients where they did the GI analysis, and they still found the mRNA of the viruses in the linings of the stomach. This was about 8 months after the initial infection. So the patients who come back to me and say, you know, I had Paxlovid when I got reinfected and my symptoms completely disappeared. Of course, they came back when I finished the Paxlovid. And so these patients are always telling me, can you put me on Paxlovid? Because look at the study. These studies show that the virus was actually there. So what if this virus is really still there? Can you give me Paxlovid? Is this being studied? Yes, I believe it's part of the RECOVER study. There is, and we all know about the ACE2 receptors. the virus has affinity to these receptors. These receptors are found everywhere. And what they do is they cause inflammation of the endothelial lining of the vascular system, leading to a DIC kind of a picture, leading to both bleeding as well as clotting. So I've had patients with clots, young patients, and then I've had patients who bled in their muscles and then having difficulty to ambulate. So there's so many symptoms and so many mechanisms. There is, and I alluded to this before, that the inflammation response that is exaggerated in the COVID patients leads to this organ damage, and based on which organ was damaged will be your symptoms, okay? So that goes to the symptomatology. This is a very interesting article as well, and this talks about, this is all the rage right now in NIH, the ability to stimulate the vagus nerve. Because the vagus nerve has the ability to lower the inflammation, has anti-inflammatory properties. And how it does that is that it through the acetylcholine, the vagus nerve stimulates the T cells and the macrophages. And this is the efferent part of the vagus nerve. It actually through the celiac plexus, which supplies the GI tract and the spleen. So it reduces the T cells, and which reduces the macrophages, which leads to reduction in all your cytokines, such as the interleukins and the tumor necrosis factors. So there are two methods of doing that currently that are being done both at the University of Minnesota. One is through stimulating the vagus nerve at the neck. This is approved for the depression. So for depression, if you have failed 4 or more ways of treating your depression, so, and I say ways are not medications because therapy is considered one of those treatment options, you are eligible to get a device put in which stimulates your vagus nerve. It's FDA approved. Insurances are still not paying for it, so you have to go to the Department of Psychiatry and get the vagus nerve. I've spoken to the company that owns that device, and they've said the cost is about $100,000 to put that in. So it's really preliminary. Why I like it? Because by stimulating the vagus nerve, you can actually reduce the inflammation. It's been shown that it reduces depression. And hopefully I'll get the time to talk about depression and long COVID. There is such a huge relation there. And I'm not saying that you're depressed, that's why you have long COVID. That's not what I'm saying. I'm saying long COVID, if it causes depression, you're not coming out of long COVID unless that depression is treated. Depression and anxiety. So enough said about this slide. And so going to long COVID in the elderly population specifically, what do we know about this? We already know that these patients have a higher mortality. When infected, patients who are elderly have a higher mortality. Their pneumonia severity index, also known as the PSI, is higher in these patients. We find that when they get infected with COVID infection, they tend to involve more lobes of the lungs compared to someone who's younger. So higher incidence of pneumonia, higher incidence of ARDS, more multiple lobe involvement if you are in that group. Now in this group, they found that the C-reactive protein was higher in the younger group. This is very important. So pay attention to that and remember it, because when I go back to that slide, I'll talk about this. C-reactive protein was higher in the younger group. Because when I was putting up these slides, and I was not convinced that from those studies that say long COVID is more or higher in the elderly population. Didn't make sense to me. Because if your inflammation levels are high and the CRP levels are high statistically in the younger population, why should they have more long COVID? It's more complex than that. This is one study that looked at it. The way they put the older age group as being a predictive factor or a risk factor for long COVID was by looking at those patients who were admitted. But if you divide the long COVID patients into two buckets, one, those who were admitted and had intubation and had ECMO, and those who never went to the hospital, these patients look very different. So by virtue of admissions in the hospital, they deduce that the risk factor for developing long COVID was older groups, okay? This is one study that showed that hospitalization was higher with advancing age. And that, I absolutely see that on a daily basis. Most of you probably see that. Because the admission rate was about 4% in the study in those patients who were 50 to 59, and was 18% in those who were above 80. We know that. Now, we also know that in this study, they found that the prevalence of long COVID in the elderly was 10% in the younger population and 22%. Now, again, if you were to take the study and separate the two buckets out of who got hospitalized and who didn't, this will look very differently. So what I did is I actually, for this particular talk, so this is completely unpublished data, and which I plan to develop into a manuscript. So if anybody is interested in being a co-author with me, so please connect with me. This is about 6,000 plus patients who were admitted in the hospital, okay? This is the descriptive analysis. One thing that pandemic did for me was it turned me into a statistician. So if you look, what I did is I made 5 buckets of these patients. Those who are under 40, those 40 to 55, 55 to 65, 65 to 80, and above 80. Now the yellow highlights are the ones that I want you to pay attention to. So if you look at the BMI, you'll see that the BMI goes up from 29 to 30, or even 32, up to 55, and then it starts going. If you look at those who are less than 80, the BMI is actually very low. And at this point, I'm thinking of sarcopenia, I'm thinking muscle atrophy you see in the elderly, you're thinking of frailty. So not really, and if you look at it, it is significant. So it gives a very good picture, right? If you look at the D-dimer, look at that. The D-dimer was so much higher in those who were above 80 compared to those who are young. The Elix-Hauser comorbidity score is actually a collection of comorbidities such as hypertension, diabetes. So the more you have that, the more you have the ability to develop long COVID. And you will see that is also high in the elderly population to 9 comorbidities. Now I looked also at breakthrough. So if you had, you were vaccinated, and what happened? And so you see that it's right there. It is statistically significant. But if you look at the numbers, you'll see that it's going up a little bit, but not so much. And I'm not very impressed. But if you look at those who developed long COVID after getting the vaccination, then you will see the difference there. It goes up from 40 to 42% to 44 to 47% up to 80, up to age 80, and then after 80 it comes down a little bit. And then of course the mortality rate is pretty high. So this is the data from our own institute. And then what I did is I did a regression model of what I was seeing in the descriptive analysis. And what I did is keeping anxiety, depression, gender, if I adjust for that, so keeping those things constant, if I look now what happens. So if you look at that, you'll see the coefficient, I've put it in yellow. Look at those who were less than 80, it's 0.3. And those who were 65 to 80 is 0.5. That shows that actually age is protective to developing PASC. And again, is there a particular reason for it? Maybe they don't throw up a cytokine storm. They do not throw up their inflammation as much as a 40-year-old does. To me, that makes more sense. What are the challenges to getting to diagnosing long COVID? I mean, some of these patients were in the families, the whole family had it, and so people say, oh, we know everybody has long COVID, so there's no point in getting Granny to the hospital to get PCR done at that time. So nobody took her to the hospital or clinic to get it done, and now I have to depend on, everybody had it, so she probably had it too. Access is one, and then what else? antibody titers, and now we have the home kits, which really helps out. So what makes it difficult to look at our population, the elderly population, versus my 40-year-olds and 50-year-olds and say, what's going on, right? So if somebody comes and tells me, I have fatigue, I have aches and pains, I have joint pains, I can't remember things, those are all the symptoms that the elderly have. These are all the common symptoms of long COVID. So how do we take into account in my analysis or any statistical analysis these factors, right? But the different things are PEM. You don't get PEM you don't get loss of smell. Sometimes they do have loss of taste. They don't have an appetite, but loss of smell, loss of day and night cycle. Because in the study where they had found the mRNA in the brain, they found it in the center that is the highest center that regulates your day and night cycle. So we believe, talking to some of the experts at the U, we believe that there is dysregulation of the sleep-wake cycle in these patients, which is why they don't know when is day, when is night. And you ask the long COVID patients, of the 7 days, how many days do you wake up feeling very rested? The answers are usually 1 or 2. They don't sleep well because their brain is completely off the cycle. So I've been starting to put them on melatonin, a small dose. Nightmares is one of the side effects, but I've been put them hoping that it will help bring back that cycle. Autonomic dysfunction, that's not normally seen in the elderly POTS, and shortness of breath, chest pain, cough, headaches. These are the symptoms that would differentiate them from others, right? So mental health in elderly is a major, major impact on long COVID. Depression, anxiety, PTSD these are the most common things that I see in the long COVID that you can see in the elderly population. In one study that we did, I didn't do this one, this is another study, I'll talk about later, but this one shows that depression and anxiety are very common, and they are associated with increased risk for cognitive decline, cognitive impairment, and dementia in older population. So very, very important to see the mental health of these patients. Now, this is one study that I was part of from the Women's Health Initiative through the NIH, where we looked at 2,980 postmenopausal women between the ages of 50 and 79. This study actually started back in 1993 to 1998. And what we did is we presented them with questionnaires now. So we had a peri-pandemic outcomes, and we had pre and peri-pandemic outcomes for these patients. And what did we find is that we did through a telephone the interview for cognitive status. This was assessed. And what we found was that every 5-point lower score was associated with 12% lower odds of practicing safe hygiene. So you can imagine if patients are in a facility and they are cognitively impaired, they will not be able to follow the safety guidelines to maintain the safety you need for COVID infection. And what we found was that lower pre-pandemic global cognitive function was associated with higher stress and depression severity during the pandemic. And higher depression symptom was associated with cognitive decline, and cognitive decline was associated with lower odds of practicing safe hygiene. So very important to know this so that we can help. And this is another study that we did at the University of Minnesota that was published in ACRM, where we analyzed 19,000 patients through natural language processing. So what we did is the computer analyzed thousands and thousands of charts, and we had certain language or text that we had given to our NLP specialist who will pull it out and find out what are the symptoms. And what we found, what we were looking for is we were looking for rehabilitation utilization in these patients. And what we found that the PASC or long COVID was present in 42.8% of our population. So that's a pretty high number. And then what we found that those patients who were men and those who were on ACE2 inhibitors 3 months prior to getting COVID actually were not going to use rehabilitation as much. That could be because they were not as sick. So I think that is fairly important finding, and we also found the higher the comorbidities, higher the risk factor to utilize this. Now, going to management, like I mentioned, the inflammatory status of our bodies is at a much higher level in long COVID. So there is unfortunately no pill that I can give anybody and say this is going to cure it, right? It has to be a multidisciplinary approach. Outside the patient and inside the patient, it has to be a holistic approach, even for the patient. So most of my treatment starts with nutrition and exercise. Now think about these patients who are fatigued. Most of them will not go out, will not do anything. They are so tired. They haven't slept for ages. They're extremely tired. And if they do something, the PEM happens 2 days later and they get punished for doing it. So what's happening is they keep on adding to their weight. Their weight goes up. They don't exercise, the muscle mass goes down. Terrible place to be. So it's about finding the right space, never to give up, but to keep moving. And so I teach my patients to grade their fatigue. If your fatigue is 7, 8, 9, don't do anything, go and rest. If your fatigue level is about 2 or 3, go and hit it. But never do you give up and not go out for a walk. During the summer, my main thing was, even if it means that you'll put on your shoe and go out, even outside to your driveway and come back, I want you to do that because I want you to build your muscles. So it's all very, very holistic. Physical therapy helps. Now, physical therapists are not one homogeneous group. There are sports, there are neurological physical therapists. So I may send one patient to a physical therapist who's going to teach the patient how to pace themselves, how to do their activities slowly through the day, when to move and not to move. Then there'll be another therapist another patient who I'll send to a physical therapist who does more of manual muscle, stretching of the fascia, stretching of the muscles. The reason being, those patients who come to me saying shortness of breath and a lot of chest tightness, we do an X-ray, do a CT scan, nothing is there. What I find is when you see these patients, how they breathe, they don't breathe like normal people do anymore. They breathe here. It's right over here. There is diaphragmatic dysfunction. There is actually development of fibrosis. This has been shown in studies at a microscopic level, that there is change of the cells from real cells to fibrosis. So the muscles are somewhat fibrous, so these patients can expand their chest very well. So we have several therapists who only do manual muscle stretching of these areas. And so I'll send those patients. So it's not like somebody comes and says, I have fatigue, blah, 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 and I'm sending them all to a physical therapist. I'm thinking, oh, this one goes to a neurological, this goes to a sports medicine, this one goes to a stretching physical therapist. So you have to know who you're sending your patients to. There are some patients, I send them out to a physical therapist, they came back and said, oh, they put me on a treadmill, and the next day I was dead almost, I couldn't get out of bed. I'm never going to physical therapy again. So that's a bad match, right? So that's very important. So counseling on nutrition, sending them to other specialists is so very important because that's how you will rule out possible alternate diagnoses. Workability in my clinic becomes a major issue because I do send them back slowly. I talk to the QRCs. I'm talking to insurance companies, disability companies. Disability companies are actually emailing me. There's one patient I had who was a physician who couldn't work, and she's applying for disability. And the insurance company emailed me saying, did you know that this patient is actually now starting her own company as a life coach? And she's quite active in the media. And how can you apply for disability? I mean, they went and searched the media to see what she was doing. And when I talk to the patient, she's saying that, yeah, my niece helped me through that. I haven't been paid for months. I'm trying to stay alive. So you can see both sides of the picture, right? So managing that becomes very, very crucial. In case of fatigue, you have to rule out other causes. And there we go. So ruling out a lot of other things such as diabetes, hypothyroidism, sleep apnea, any other cause that can help with the fatigue. There is a rule of tenths by APMNR consensus statement, and it's a very interesting rule based on your fatigue levels. Start with a certain amount of exercise time duration, and after 10 days, increase that duration and intensity by 10%, and keep doing that. So I find that quite helpful in many patients. Nutrition, I propose the anti-inflammatory diet. Very tough for our country, very tough. Because what we are saying is no, not even protein bars. Just eat the simple thing. You want sugar, eat a fruit, vegetables, less red meat, no sugar whatsoever. And I've been telling people, if you look at the sugar, it's a white powder. If I gave you a white powder and didn't tell you what it was, and I said, make a nice dessert with this, put like 4 cups in it, would you do it? But we do it, right? Because we all have been built into this. But this is a major problem with where we are in terms of our inflammation levels. And you can't lie to the body. It'll never let you lie. What you eat is what you will be. So you have to be very faithful and eat the right stuff. And then the symptom, okay, so yeah, and then I talked about the perceived exertion scale or scale of fatigue and so on. So that's fatigue. Post-exertional malaise, I do send these patients to PT, OT, pulmonary rehab, depending on what I'm seeing in terms of symptoms, cardiac rehab. You have to make sure that their pulmonary and cardiac symptoms are being evaluated if you feel that there is something to be worried about. There was a study that just came in talking about naltrexone as a possible treatment at 1 milligram daily. Normally, when it's used as an antagonist, it is at 50, 60 milligrams, but this is 1 milligram. We've tried all our group that we meet once a month. It's both national as well as at the U. We have tried some of them. For some it worked, for some it didn't. The reason being, again, there will not be a one pill to treat this. You'll have to take the holistic approach. Paxlovid I talked about earlier too. How are we doing with time? Okay. Brain fog is up to 81%. We talked about how the virus goes into the brain. Some studies have talked about transmission via the olfactory bulb. In my clinic, we do mini-cog, we do mini mental test. I do have my therapist do MOCAs and slums. I do have neuropsych testing done. I have seen patients who have TBI or concussion. Their symptoms do get unmasked. I have used Ritalin, modafinil, Aricept with some success, but it's not a go, this is it. Mental health, what I have found in my clinic, and this is anecdotally, if somebody is depressed, if their PHQ score is high, there is no way their long COVID is going to go away. I have to treat it. It's a reverse causality, not that it causes long COVID, it's a reverse causality. And so you have to treat it with medications, with therapy. Make sure that they have social support, which is very important. And that's where the vagal nerve stimulator comes to me. Because I have many patients who have tried many, many medications and nothing helps. I will pass this on, and this is the APMNR consensus statements. They have a lot of consensus statements that I would recommend that you look into. Autonomic dysfunction, very, very important. These patients develop dizziness, syncope, palpitations. I will send them to a cardiologist and to manage their POTS syndrome where they have tachycardia. There is a very interesting way how this develops, but unfortunately I don't think I have the time to say that. The approach to POTS, which is education, that it's okay. Exercising regularly, both with aerobic and resistance. You have to tense the bigger muscles of your body to actually keep the hypotension from developing. And make sure that you are hydrated well, salt tablets, and avoiding exacerbating factors such as avoiding coffee and alcohol. Overall, I would say long COVID is here to stay. It's a major, major public concern, health concern. It is impacting the disability and the workability of our people, so it's going to stay, unfortunately. These are some of the references I have besides the one that I've put in the slides. Thank you for having me here.
So we do have about 5 minutes for questions.
Hi, I'll ask a question. When you were talking about whether long COVID is more or less common in the elderly and how it makes sense that the inflammation is higher in younger people and that would make more sense with long COVID, I'm also wondering about how, the thoughts that long COVID isn't just one entity, but possibly several things under one umbrella, and so maybe other forms of long COVID might be more common in the elderly, not just the hospitalized, because a lot of our patients don't go to the hospital, never have respiratory symptoms, but they still develop something like
Yes.
persistent fatigue, or they stop eating as much and lose weight and kind of unmask for their dementia, things like that. So just wondering what your thoughts are about that.
Yes, you are right on about that, because the state of being in a hyperinflammation is only one of the mechanisms of how you can get long COVID. Several other ones that really come to my mind is one is the dysfunction or dysregulation of the sleep-wake cycle. And this can exist in our elderly population. We also know there is autonomic dysfunction. The interaction between the immune system and the neural system can also lead to long COVID. So these would be the alternate ways how long COVID can be affected. It's going to be so difficult to figure out between the symptoms. And the very few patients that I have who are in their 80s in my long COVID clinic, you talk to them, they're there, but they don't want to say anything. They're like, yeah, I'm tired, but yeah, it's okay. So they really minimize their symptoms. So you really have to work hard at really pulling out what is there and what's not. So very good point. Thank you. Yes.
Hi, very nice talk. You had a slide earlier on, and I don't remember the details, but I think you were talking about the population of people that were in the hospital with COVID, and they had the presence of PTSD.
Mm-hmm.
Could you talk a little bit more about that? Were these, and what the nature of that PTSD? Were these people that were intubated, or do you want to talk a little bit more about that?
Oh, yes, absolutely. So I've seen PTSD in both the patients who were hospitalized as well as those who are not hospitalized. So in those that are hospitalized, the PTSD is almost anxiety producing of the breathlessness that they had at that time. And many of them, especially those who had ARDS and are still on oxygen, for them that breathlessness that comes in, or the shortness of breath that comes in with a little bit of activity that was not their baseline, that PTSD comes in right away. Among those patients who are outpatient, who were never admitted in the hospitals, they have PTSD because they fear going out in society, actually. Many of my patients worry about going to a gathering of more than 2 people. They're afraid to go to a party. And so they are all intertwined between PTSD, anxiety, and depression. And that anxiety leads to depression because there is so much social isolation because of that PTSD of going out and maybe getting another acute infection and having re-emergence of all the long COVID symptoms that they had. I am seeing in my clinic many patients who were doing better almost were at the tail end of it and then got reinfected, and all the same symptoms came back, and they went back several months. So you can imagine the PTSD of getting that infection again. So I see that in both the populations. Great question. Yes.
How are you using Paxlovid dosing on a long-term basis as opposed to like the 5-day course?
Yeah, that's a great question. So I have not used it. I have had many patients ask me for it. And so you cannot, the FDA approved, which is also, it's for a short while, is only for 5 days, and it's within a certain period of time when you have an acute infection. It has not been approved for long COVID at all. Patients ask me, but I have never been able to. It is being studied, yes. So I don't know the dosing on the study that is being done by Recover yet. Yes.
So what's the population, male versus female? Can you tell me a little bit about, I'm thinking to myself, maybe women will be underreported because we multitask so much and we think, I'm tired because I've done so much today. Can you tell me a little bit about that? Because I'm just thinking about it sitting here.
So you're asking me the incidence of men versus women? I think, let me see if I can bring that up. I mean, in my outpatient clinic, I definitely see more women than men. We know from many studies that, yes, it is more women than men. Not this one. So even if you look, this is only, if you look in this population, we have 32% less than 40 are men, the remainder are women. Here 55, 56, 50. So as you age, that is going a little bit different, but in the younger population, it's mostly women. And that's the population who really seeks out a long COVID physician because it impacts their life. They have little kids, they have a job, so they come out because of the workability issues and whatnot. Yes?
Question regarding how do you counsel patients regarding the prognosis of long COVID? Like, what are the studies that the data show? Like, which symptoms improve, which symptoms resolve? What are the duration of improvement?
Yes, I think that's a great question, and I hope I can answer that more anecdotally from my own experience rather than from studies. I have patients who, in my clinic, every day I discharge a patient from my clinic saying, I think you're good. You don't need to be back seen anymore in the long COVID clinic because you have recovered. And that's the hope I have. So I have some patients, many of the patients who do recover between 9 and 12 months, I would say. There are a few that have gone beyond 18 months, and I have a few that are 2 years. So those do exist too, and those are the ones that, they have a lot more comorbidities as well. But yes, many do recover. Most recover.
I think we need to end it there. Can we stay a minute? Yeah, sure. Come on up if you have further questions. Otherwise, I'll have a